Okay, so we're going to move on to our next speaker. I had the privilege of doing residency with Dr. Elwood. I've known her for a long time and
Forever. It feels like forever, right?
forever.
Caleb was my chief for those who are not
And
on. So,
Dr. Elwood, we're so happy to have you. So, Dr. Elwood did her bachelor's and master's in microbiology and immunology at Western. Then she worked in infectious disease research as a microbiologist, and then she did her medical training at UBC. She did an OBGYN residency and then a fellowship in reproductive infectious diseases here at UBC. So, Dr. Elwood does general OBGYN, but she is also wears many hats as the medical lead for the Oak Tree Clinic, as well as which treats families with HIV and RID. And she works in the provincial and national level to forward reproductive care for women and children and families impacted by reproductive infectious diseases. So thank you very much for being here, Dr. Elwood. She is going to talk to us now about infectious disease screening and treatment, pearls for preconception and pregnancy.
okay. Happy to talk. Somebody just tell me you can see my slides, yeah?
Perfect. Yeah.
Okay, let's roll. So the good Dr. Dunn asked me to do this talk, and I was like, oh, that sounds like a great talk to do. And then I sat down to think about how to tackle this topic, which is a very large and broad topic. And what I'm going to do is just give you a sampling of information around infectious disease prenatal screening and preconception screening. And then I am very happy to answer questions and what are the burning topics that you guys are experiencing and questions that you have, because this is a massive discussion in general and an ever evolving discussion. When I agreed to give this talk, I thought our biggest conversation would be about CMV or Zika or something like that. And now rubella seems to be the latest conversation that we're answering questions about. So I'm happy to answer questions at the end. Okay. I always do a land acknowledgement, and I guarantee you guys have done one at the beginning. But here's the reason that I do it again, and I'll explain why. So I work on the traditional unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I do think it's important that we pause and we reflect on racism, discrimination, Indigenous peoples, non-Indigenous peoples, and their interaction and interface with medical care and infectious disease. And in particular with infectious disease, all of those social layerings and intersectionalities are huge. Infectious disease in general is dirty, unclean. It means you were doing something with somebody, because a lot of our infectious disease screening is sexually oriented. And when you come into that with that type of lens, you recognize that the social constructs of screening around infectious disease is impacted by those things. And in particular, our Indigenous peoples have had infectious disease weaponized against them. For example, smallpox blankets. So when you're having a conversation with someone about screening for infectious disease and screening for HIV and pregnancy, and for example, they come from Eritrea and Africa, their lens is going to be very different around screening for HIV, and you have to be thoughtful about those things. So I really do think it's important to re-acknowledge this sort of equity lens and the impact that that has on infectious disease. So the learning objectives are current antenatal screening recommendations. We're kind of going to go through and really just gain some pearls in infectious diseases and pregnancy and preconception screening, okay? And here's sort of a general overview of how to sort of think of infectious disease screening and treatment and all those things in pregnancy. So in general, you have a preconception window where you have an opportunity to do some things. You have a pregnancy, like a positive UPT or a positive beta HCG. What do I order? You have ongoing screening in the pregnancy. And then what do we do postpartum? And I'm going to try and highlight a few things as we go through the different diseases that highlights these different sort of areas as you interface with RID. Okay, so for example, when you talk about preconception screening, you're doing a risk assessment of the individual. So the individual's coming to you as a fertility conversation, or they're coming to you for a well woman type visit, and you say to them, hey, are you planning to be pregnant in the next future? Yeah, if so, we should probably send you for some prenatal blood work because we all just ordered the same darn thing, to figure out if you're immune to everything I need you to be immune to, you don't have any infections I'm worried about. But what I would ask you is to take a step further and think of that individual if they're a newcomer to Canada. Or do they require any vaccinations? Did they miss their HPV vaccine, which has nothing really to do with screening in pregnancy, but that's a well woman visit that you have an opportunity to offer an intervention that's going to reduce their risk of cancer. So there's that preconception piece, right? And then you're arriving at that pregnancy and they're pregnant, and you're going to order that tick box that exists in the province of BC. And you're just going to order all those blood tests and then have to interpret them. So we'll talk about that. And like, are there ongoing risk exposures? Should I be rescreening? Do I have to screen for unique things? Are there vaccines that they should be getting? And then that ongoing risk-based screening based on their current lives, how they function in society, or travel or things like that, people they're exposed to, their sick toddler, the daycare they work at, all those things. And then postpartum, re-engaging them with primary care if you're not their primary care provider. And how do we ensure follow-up for hepatitis B for a neonate, those kind of things, okay? So voila, here it is. Here's the antenatal record in BC. And we were just having a discussion amongst my ID colleagues in general ID about why the antenatal looks like what it looks like and why we just order the package. And the package of blood work looks like this, and the infectious disease component of things. And you'll notice it's like a whole big section. So you screen for, hang on, too fast. You screen for rubella, you screen for HIV, you screen for syphilis, you screen for hepatitis B, you screen for gonorrhea and chlamydia, you do a urine CNS, and I'm not going to talk about GBS because that's a more labor-oriented conversation. But why? Why are we doing that? And why does it matter? And what do we do with an abnormal result? And so we'll go through all of these, and then we'll go through a couple of other things. So first on your list is rubella, right? So why are we screening for rubella? Rubella is rare in Canada, like super rare. But congenital rubella is absolutely devastating. So if an individual acquires rubella in the first trimester of pregnancy, there is a 90% chance that that fetus will have significant birth defects. Okay, and that's historical data, which is why it still says defects. But 90% chance that that fetus is going to be significantly impacted. And the risk is about 80% that that's going to happen. So of those 80%, 90%, it's not great. And congenital rubella is almost fully preventable by vaccination and immunization. And so in that preconception conversation, ensuring that your individual is either screened for a history of 2 doses of rubella vaccine, and or you do screening serology to ensure that they are considered quote unquote immune to rubella is hugely important. And here's where that DAI piece comes in. The vast majority of the cases of congenital rubella, and we still see cases of congenital rubella in Canada, are in those who are newcomers and those who have other sort of things going on. And so you really have an opportunity to help the individual in front of you by doing that preconception screening or identifying for that individual in front of you that as a pregnant person, they are non-immune to rubella. And in all pregnant people who are non-immune to things, we say avoid sick people, but we really, really need to say avoid sick people for this one in particular, okay? And so in BC, we've taken a strategy of serology for all individuals who are pregnant. For example, other provinces, they take a history, and if you give a history of 2 doses of vaccine, then you don't actually need to do the serology. It's a bit mixed on how accurate those is and that approach is, but certainly that's the approach that we've taken. And for those individuals who are non-immune and actually pregnant, then they should receive a dose postpartum. For those individuals who are preconception, then they should receive their MMR, which is what we have in Canada, primarily measles, mumps, rubella vaccine, okay? It is a live attenuated vaccine, so we don't give it in pregnancy, but there's never been a case of harm from any of those particular types of vaccines for an individual who's inadvertently vaccinated, okay? One of the common questions we get on the call line is, I have a patient who's not immune to rubella, and if we remember back in March, there was the whole measles scare. Is that considered immunity? Like, can you correlate those 2 things? Because we primarily give MMR, the answer is no. If you're looking for measles immunity, you actually need to test for measles immunity, although they're very rare. Vaccine failure rates are exceedingly low. So that's a little bit about rubella and why we still do it, okay? HIV. So next on that antenatal record is an HIV screen, okay? And I think this is really important, and it continues to be important, and I'm gonna kind of walk you through why. So in that preconception visit, you have an individual who's planning a pregnancy or is thinking about a pregnancy. An HIV screen is a good thing, okay? For that individual who's sexually active, an HIV screen and knowing their HIV status is a good thing. It is a part of your prenatal serology practice, package. And what actually happens on the backside is you draw an HIV prenatal sample. What you get is a 4th generation ELISA for P24 antigen, which is the HIV itself, and antibodies to the HIV. Okay, 4th generation ELISAs are extremely sensitive tests. If that initial screen comes positive, then there are multiple confirmatory tests that happen behind the scenes, and then you get a result provided to you, okay? And this is important for those of us who order HIV screening, because sometimes you get that funky result where it says P24 or antibody test was positive, but confirmatory tests were negative. This likely represents a false positive, but a sample should be redrawn in 2 to 4 weeks, okay? And that's because we want to be really sure not to miss this one and not to miss this diagnosis and not to get this wrong. And so, yes, false positives do occur. The false positivity rate of this testing algorithm is less than 1 to 2%, but it does happen. But it certainly absolutely warrants the follow-up conversation and the follow-up. It's hard to handle that conversation often with patients. And if you're not comfortable doing that, we are happy to support you in that conversation and explaining those false positives. But they do occur sometimes, just not very often. Why does HIV really matter for pregnancy and pregnant individuals? Because antiretroviral therapy is a game changer, okay? Prior to antiretroviral therapy and triple therapy in pregnancy, the rate of transmission sat somewhere between 40 and 90%, depending on if this was newly acquired HIV in pregnancy or older HIV that had been transmitted after. You introduce a triple therapy. Antiretrovirals are safe in pregnancy. They're now 1 tablet, once a day regimens. And if you're compliant with your medications, the risk of transmission to your baby is basically 0. Okay, if you choose not to breastfeed, and that's a separate topic for a separate day. But really, we have great therapy. And we have the ability to absolutely interrupt congenital transmission. And I'm always shocked to find that not everybody knows that. And so when you're sitting in front of an individual and you're counseling them on pregnancy screening and you're talking about why HIV testing is important, it's important for the health of the individual in front of you. But often you can leverage that conversation around the unborn baby. We need to test so that your baby doesn't get HIV if you have HIV, okay? And we know that untreated HIV has really negative outcomes for on the maternal side as well as the pregnancy side. We know despite all of that, that we still really do see this is a high-risk pregnancy. And we have a preterm birth rate. I'm showing you the preterm birth rate here in BC that is higher than the average population norm. So our preterm birth rate averages out to about 20% for individuals living with HIV despite antiretroviral therapy. So it's still a high-risk pregnancy. But certainly the pregnancy outcomes are much improved when you're on antiretroviral therapy. And we're always happy to support. And the Oak Tree Clinic remains the pregnancy clinic in the province of BC. We are sort of the prescribers of antiretrovirals in pregnancy and here to support you with a new diagnosis in pregnancy and sort of talk your patients through that. I will say that handling a new diagnosis, so you order the test and you got a positive outcome, we are always happy to talk to you about how to have that conversation with your patient. And one of the things that people need to understand about that conversation is around safety for the individual in front of you, safety for that individual with their partner, because about 80% of individuals will experience violence as they disclose their HIV status to their partner. So we're always happy. We will do that conversation for you. We will support you in that conversation, whatever we can do, okay? From a general perspective, though, around HIV and preconception care, U equals U. So if you have an individual, male or female, living with HIV and they're on antiretroviral therapy, the risk of transmission to their partner, if they're on antiretroviral therapy and their viral load is suppressed, is 0. Okay, and that's from good data from France and over 1,500 patients in heterosexual couples. There were no transmissions. So from a preconception perspective, you can allay those fears around disclosure. You can allay those fears around transmission to a partner if the individual in front of you is on antiretroviral therapy. And that's a really important thing to know as a provider, because it's a bit historic where we used to think we had to tell everybody those things, okay? And you actually don't, because you equals you in those circumstances. And the last piece I'm just going to briefly talk about for HIV and pregnancy is the concept of breastfeeding. And this is, again, hugely important. And that covers this postpartum piece around infectious disease screening and common piece, okay? Breastfeeding is breast is best. That's what we see everywhere, right? And for an individual living with HIV, we still recommend formula feeding as the feeding modality of choice, because despite being on antiretroviral therapy, because breast milk is immunologic, there's about a 1 to 3% risk of transmission of HIV to an infant with breast milk. We are seeing more patients choose to breastfeed. We're happy to support them to do so. It's a complex process. But you will maybe now occasionally see some people breastfeed. What you also need to know is around that disclosure and that EDI issues. In a lot of countries, when you don't breastfeed because you have HIV, and that results in inadvertent disclosure to communities and inadvertent disclosure to families, where individuals may not have shared their status. And again, that comes with a risk of social stigmatization, isolation in a postpartum period, and violence. So those are very important things to know about. I'm always happy to chat you through them. I'm also going to take a bit of a speaker's sort of leeway to talk to you about PrEP, okay? We are bad at PrEP, to be honest with you. So PrEP is the concept of pre-exposure prophylaxis for people who are at risk of acquisition of HIV. And it has been shown to be very effective, like 80 to 90% reduction in acquisition of new diagnoses of HIV, okay? And if you look here in BC, we're very good at prescribing PrEP to cisgendered males, okay? We are very bad at prescribing to cisgendered females, okay? And you can see the axis on the left-hand side is completely different between those two figures. They've actually had to separate them out now. What we're not great at doing is asking our patients if they may be at risk of acquiring HIV and whether they would be good candidates for PrEP. And I would encourage you all in your preconception visits, your conception visits, when you're seeing a pregnant individual, to start screening, because all of our drugs are safe. So we tend to use something like Tenofovir, Truvada, and it's a very safe drug. And we have an opportunity, because where we do see, we've seen a couple of transmissions to newborns and neonates in those individuals who probably should have been on PrEP, and we've missed a window of opportunity to prevent that transmission. And so we can walk you through that process of asking about PrEP, and I'm happy to talk more about that. Okay, so next on that list, so we did our rubella screen, we did our HIV screen, and voila, we're going to talk about syphilis, because that is the #1 phone call I'm getting these days. And all of us who are doing this work, I triaged 18 referrals for clinic, and 12 of them were for syphilis in pregnancy. Okay, so this is data coming out of BC. I've updated the quarterly data here, and you can see the alarming increase in the number of diagnosed cases of syphilis during prenatal screening by quarter. And so in 2012, we had basically nobody with syphilis in pregnancy. And yes, there have been some screening changes, but I'm going to show you that data. That's not really what's going on. We are seeing an alarming increase in diagnosis of syphilis in pregnancy. And what has shifted, and why does this matter to you who might be seeing a patient for preconception or seeing a patient at their first antenatal visit? So in 2018, the vast majority of cases of syphilis, almost 80% of them, occurred in this blue bar right here, which is male case in a male partner only. So men who have sex with men, okay? If you look now and you look at 2023 Q2, what you're actually seeing is the proportion of cases has decreased in the MSM population and has increased to 37% for men who have sex with women and 34% for women who have sex with men. And so it's basically flipped. And when that happens, when you have men having sex with men, then pregnancies occur. And so what we see is that matching increase in the number of diagnoses in pregnancy. Again, we are seeing, like, remembering that we are seeing stages of syphilis. We're seeing early syphilis, secondary syphilis, and I'll talk about those briefly. But we are seeing syphilis across the board, and also remembering that neurosyphilis occurs in any stage of syphilis. So neurosyphilis, although we think about it in our training as being latent kind of manifestation, can actually occur at any, okay? And yes, we did increase the syphilis screening rates by introduction of a delivery screen, but despite that, we are actually seeing an increased rate of syphilis, and it's largely because it's moving across the prairies, and so the rate of positive per test is actually much higher, okay? And unfortunately, what we are again seeing is the matching number of congenital cases of syphilis, and that's really tragic because congenital syphilis is completely preventable with appropriate screening and treatment. And the intergenerational lasting effects of congenital syphilis are enormous. And if you want to go back historically and you look at things like the Tuskegee trials, the impact of that is not small moving forward, not only for that particular baby, but also that family and the other parts around that, okay? So syphilis testing, and syphilis testing is confusing, but I'm gonna kind of walk you through a little bit what syphilis testing looks like primarily here in BC, and also what you would have historically heard about and seen. So syphilis testing, there's basically 3 groups of tests, okay? There's a 4th one that we have in BC that's kind of new. So when you were looking at the traditional syphilis chancre or primary syphilis, we're all taught to think about dark field microscopy. What I'm going to tell you is that has largely been replaced with PCR now, okay? And you can actually, if you think you got a herpes lesion these days, you probably should screen for syphilis. Or if you think you've got some other ulcer on the vulva, you should probably screen for syphilis, okay? To the point where, give me an example. So we were seeing a patient at the clinic for management of long-term lichen sclerosis, and we looked at it and we're like, it doesn't quite look like lichen, but it's probably lichen. So we'll give you some clobetasol and we'll do a biopsy. So we did the biopsy and it was syphilis. So even we got it wrong. So anything sort of that you might think might be syphilis, what you can now do is a PCR. You can do that PCR on your gonorrhea and chlamydia swab. You can also do it on an HSV swab. You need to write on the requisition, syphilis PCR. It will go through the BC CDC and be screened for that, okay? The other 2 groups of serologic testing is the non-treponemal serology and the treponemal specific serology. And what we know is non-treponemal specific serology that I'm going to talk about is the RPR, and treponemal specific serology is usually looking for either the antigen or the antibody, okay? And the algorithms used to be RPR first, treponemal specific second. What you need to know now is that treponemal specific occurs first, okay? It usually takes about 2 to 3 weeks to be detectable, and it's very sensitive and specific when it's there, okay? It doesn't tell you whether there's active syphilis, but it does tell you that this individual in front of you has seen syphilis at some point in time in their life, okay? There's basically almost no false positives to this test. The RPR test is that marker of disease activity, okay? So when we think about a lot of our testing, we think about HIV testing, we have that initial ELISA screen, and then we do a viral load. That's our, marker of how much active HIV is. When you think about hepatitis B testing, you do your hepatitis B, and then serology, and then you do the hepatitis B viral load. That tells you whether you have active hepatitis B disease. This is syphilis's version of that. So you do your treponemal specific test, and then you do an RPR, okay? It's usually positive within about 3 weeks of developing a chancre, and has a pretty good sensitivity, but the sensitivity falls off when you get into late latent syphilis. So in order to interpret your syphilis test result, you need a couple things. So you need your treponemal and your non-treponemal tests, so your syphilis serology, and you also need your RPR, but you also need the human in front of you. And that's because that treponema specific test is going to be positive forever. And that RPR is how you're going to interpret this, okay? And so, for example, if you look at this screening and you look at the non sort of RPR treponema specific test, it's reactive, and you have a confirmatory assay, then you probably have syphilis at some stage. And the staging is dependent on last testing and risk, okay? If you have a reactive treponemal specific test, but a negative RPR, well, it's probably usually treated syphilis, could be a really early infection, or it could be really late syphilis that has gone in, done its thing, and is now quiescent in the body. Okay. And so you do have to sit down and kind of sort through these. The good news is if you send that test off here in BC, the BC CDC syphilis team will find you and they will help you interpret it. And so will we. So if you have a question of a pregnant person, you can call the Oak Tree clinic. We will happily answer your questions about syphilis and pregnancy. But the BC CDC will help you interpret these tests. And we've been documenting and tracking syphilis in pregnancy for more than 50 plus years now, and have really the records for everybody in BC. And so the syphilis BC CDC team can really help with that, okay? I'm putting syphilis back on your differential diagnosis because that painless chancre from a gynecologic perspective is often misconstrued as your differential diagnosis for what used to be HSV, but now I think you need to throw syphilis way back up here. But we're also missing some secondary syphilises where the spirochete goes systemic and you get unwell, you have fevers, rash. Palmar plantar rashes are syphilis, syphilis, syphilis. They are syphilis. That is what they are. There's very little else that causes a palmar plantar rash like that, okay? But we're seeing other things. We're seeing rashes, itchy hands and itchy feet being called cholestasis of pregnancy and other things. Syphilis has to be back on your differential now, okay? Early latent syphilis occurs after the secondary syphilis resolved, and it's that asymptomatic window prior to 1 year. After 1 year, we consider it late latent syphilis. Late latent syphilis is not transmittable to a sexual partner. What we think is it is not infectious except in pregnancy. And that's really important, okay? So the risk of transmission is like 60 to 90% for primary syphilis. It's about 40% for secondary early latent and less than 10% for late latent syphilis to a neonate, okay? There's still risks associated with syphilis and pregnancy. We are seeing absolutely unequivocally spontaneous abortions. We are absolutely unequivocally still seeing stillbirths. We're still seeing high drops. We're still seeing high rates of preterm birth and perinatal death, okay? With treatment, those risks reduce to 1 to 2%, but they do not go away fully. And so these are considered higher risk pregnancies, okay? From a treatment in pregnancy perspective, penicillin is the answer. And that is the only answer and continues to be the only answer. And so I currently have a patient that we're trying to support treatment for in Nanaimo who has a true anaphylactic reaction to penicillin, who needs 3 doses of benzathionine pen-G. And it's not standard pen-G, it has to be benzathionine pen-G. And we're trying to support a delabeling protocol for her at an alternative site. This is also sort of just a general plug for if you have a patient with a penicillin allergy and amoxicillin allergy to actively try and drop the label. So there's lots of PenFast algorithms. I'm going to show you our first line app in a little bit. You can use that to delabel your patient because 98% of those allergies are incorrect, or at least send them for testing either in pregnancy or outside of preconception, okay? This is how we follow treatment afterwards, but suffice to say this is a higher risk pregnancy. Okay. Next on that list is your hepatitis B. Okay. Hepatitis B matters from both a pregnant person perspective as well as a baby perspective. And really the risk once a patient acquires hepatitis B and becomes a chronic carrier of hepatitis B, they do have a 25 to 30% risk of cirrhosis or hepatocellular carcinoma. So this is not benign. So this is the individual where you do their preconception screening, you do their antenatal screening, whichever one you do. And if they do have hepatitis B, then you do engage them in the care pathway for follow-up with either a hepatologist, an infectious disease doc, or a primary care physician who's comfortable managing and following hepatitis B, okay? This is the serology that everyone hates and everyone has to look up for sure, okay? But good news, bad news, when you send it as a prenatal sample, you will get a viral load, and that will simplify your interpretation. So if you have an individual who has chronic hepatitis B, so has the hep B surface antigen, is anti-hepatitis B core positive, an antibody and anti-hepatitis B surface antibody negative, so that's chronic infection. Reflexive viral loads will be drawn if you tick the boxes of prenatal serology, and that will give you a sense of whether this individual requires some form of treatment in pregnancy. Why do we treat in pregnancy? We treat in pregnancy because there is an increasing risk of maternal to child transmission with increasing viral load. And so our HBIG, which is the what we give babies after delivery, so we give them both HBIG as well as immediately vaccinate them, it's 95% effective. But the 5% are for those individuals with a high viral load, where it's just not quite enough. And we know that that makes a lot of sense from a viral perspective. So we do offer treatment for those individuals, and we offer tenofovir as the drug of choice in pregnancy, and we do offer treatment above about 200,000 international units. So if you have a person who has a positive screen, you now get reflexive DNA, and that DNA will tell you instructions on, hey, this patient has a high viral load, consultation with an obstetrician or infectious disease should be indicated, okay? And that's why what is important for that postpartum period is that 25% of only 25 to 30% of neonates who receive their first vaccine in hospital receive their second vaccine in an appropriate time frame. So we're missing like 70% of those kids who should be vaccinated in a household where there is ongoing risk of transmission. So that's really important to ensure that follow-up. Okay, just a quick chat about the next on your list, which is your gonorrhea, your chlamydia, and your trich, okay? And I'll talk about trich in just a second. So gonorrhea and chlamydia, you get a urine screen for. That fancy or new, most of it, like we're basically doing PCR, our nucleic acid application for this. It's about 99% accurate. Yes, there are rare false positives. Yes, it's spectacularly rare, but it does occur. We are seeing increasing rates of chlamydia in BC, and this is BC data showing those chlamydia rates, and we are seeing those cases increase in females, actually. And so that's a group that we need to pay attention to. Trichomoniasis is not on your standard screening recommendation, and the reason for that is really complex. It's not a reportable disease. It has not been completely clearly been associated with adverse pregnancy outcomes, but it is an STI. So I would argue with you, if you screen positive for one STI, you should probably screen for them all. And so those individuals, for most part for trich, we're also doing that, okay? I'm also going to put in a plug here for things like gonorrhea. We are seeing increasing antimicrobial resistance, such that the CDC has recently changed their recommendations for treatment for gonorrhea. And so if you're not 100% sure where you're at, it's always important to just look that up. The BC CDC will also happily provide you with antimicrobials for your office and leave them to you to be able to support and prescribe, okay? The last one on that list is screening for asymptomatic bacteria. This is the Canadian Task Force recommendations, is recommending screening for asymptomatic bacteria in the first trimester with a urine culture. And this applies to all pregnant individuals. If I think you have the UTI, you should probably just treat it like a UTI and screen for it. And this is because of the data showing that it has been associated with low birth weight infants as well as a kidney infection, okay? What I am going to put in a plug for you here is this First Line app. It's totally free for you to download. It's not sponsored by anybody at all. There is a BC Women's Hospital is one of the sites that supports this app. And so myself, my AMS pharmacists go in, and within that, within every antimicrobial and every pathogen, we've included safety data for pregnancy and lactation. So if you want to look up amoxicillin, we've got safety data for pregnancy and lactation for amoxicillin. You want to look up acyclovir, all those things are there. And so you can actually get very specific pregnancy-related data that is up to date, okay? Last sort of couple of things is this concept of a torch infection. And I'm just going to frame this out a little bit, okay? So torch infections are highest risk in the first trimester of pregnancy of having an affected fetus, but in general, the lowest risk of transmission to a fetus. In the third trimester of pregnancy, they have the lowest sort of impact on a fetus if it does occur, but their highest risk of infection. And that's just really logical because embryologically, hearts, lungs, and kidneys are generally made in the first trimester, and a torch infection is generally considered teratogenic. And so you do see those changes mostly there, okay? So congenital varicella is the highest risk in the first and second trimester. There's almost no risk in the third trimester, okay? And from a preconception screening and an antenatal screening perspective, those without a history telling you I had chickenpox as a kid, which is actually going to become more of our population because we move generationally to those who receive vaccine, should be vaccinated postpartum if they don't have a history of having varicella or if they're found to be non-immune. And I don't have an answer for you today, where I think we're going to struggle a little bit in the next little while is you get clear immunity from vaccination for about 20 years post-childhood. And we're waiting as the data comes through around that immunity looks like as people age. And if you think about people who are becoming pregnant, that's more and more the crowd that we're actually seeing, okay? So I don't have an answer for you there. But generally, if you have a person who's considered to be non-immune, then we would offer a booster at the end of pregnancy, outside of pregnancy. And we're going to a little bit TBD on what that means moving forward. Okay. CMV. CMV is challenging diagnosis to make in pregnancy because the test isn't that great. Okay, and if we think back to our first principles and IgM response is the first response our body makes to any infection, and IgG response is the better next infection response we make. And what we're really looking for is a documented seroconversion from being either IgM and IgG negative to IgG positive. Screening for CMV is recommended in those individuals who have a mononucleosis type illness in pregnancy. And I'm going to talk about the screening recommendations in general in pregnancy, which is not universally recommended to check people for CMV. The IgM for CMV can remain positive for years, like years, okay? I've had patients in the clinic be positive for 7, 8 years. In addition to that, although primary infection is the worst for pregnancy outcomes in terms of affecting a fetus, we do see either reinfection with different strains or reactivation, and there is a conferred risk for that as well. So interpreting the serology is particularly challenged, and I don't have a lot of treatment in pregnancy, so it's not universally recommended to screen for it. If you look at the SOGC guidelines, there is an opportunity potentially to screen those individuals who are at high risk as CMV primary infection. So for example, your daycare workers. The challenge is, what do you do with that information afterwards? And you need to have a very thoughtful conversation with them about what you do with that information afterwards, because the best sort of thing is good hand washing, good hand hygiene, but we don't really have any great prevention. What I can tell you, and what is probably coming, is there is a CMV vaccine that's being developed on the mRNA platform, and it's really targeted at reproductive age individuals to be able to prevent transmission. So the message that being CMV immune is a little bit misleading because of that reactivation, reinfection conversation, but also from a primary infection, you can't avoid the world. And so really good hand washing, good hand hygiene is the big thing, right? And we're really worried because if you do have that sort of primary seroconversion in pregnancy, then about 15% of babies will have a major sequelae at birth, okay? And then the last thing I'm going to sort of jump into is these emerging infections or newcomer screening, and then I'm happy to take questions. What is a reasonable approach to the newcomer to Canada in front of you? And I put this in there because there is this misconception out there that as people immigrate to Canada, they have all kinds of screening done. And that is untrue and inaccurate. The only thing that you can sort of reliably think that an individual who's presenting in front of you, who's come to Canada as a newcomer, has been screened for most of the time is TB-ish. Everything else is off the table. because it's not clearly streamlined at what people are coming through with screening for. So this University of Calgary puts this out, but there's a million algorithms out there, but things that you need to think about from an infectious disease are sometimes captured in your prenatal screening. So hepatitis B surface antigen, most of us universally screen for hepatitis C, and I'll make a comment on that at the very end. HIV, varicella, we have a conversation about that. But what maybe you're not on your radar is, do I need to screen this patient for strongy because they're coming from Latin America, the Caribbean, Africa, or somewhere where they might have an intestinal parasite that they need to be screened for? Schistosomiasis, genitourinary urinary schistosomiasis in particular, has some impacts on fertility. And so screening individuals from endemic countries, you probably should screen them. And then also, that syphilis and the urine gonorrhea and chlamydia. It's hard to sort out and know what you're looking for when you do that. But certainly, somebody's looking for me clearly. What can help you is a couple of things, is the CDC guidelines. Like CDC will go country by country and be able to tell you what is endemic in that country and what is at risk and needs to be screened for. And then also if you have travelers, and this is the other piece about ongoing risk screening in pregnancy, which is if you have someone who's going to Ethiopia or have someone who's going to somewhere else, you can actually screen them and look at whether they need malaria prophylaxis. And yes, malaria prophylaxis is safe in pregnancy. Whether they need to be updated in terms of their Twinrix vaccine, they need a Hep A vaccine or something like that. So all those things can be looked at and you can find those things. And I find that I turn to the CDC Yellow Book and the CDC Travelers Resources to figure out what's endemic in what areas. But those are things that we might not think about as much as prenatal care providers and people doing preconception screening. Okay. We got some emerging infections, and this is just from common questions that I'm getting. Is Zika still a thing? The answer is sort of. So Zika virus, for those of you who aren't as familiar with it, there was a large outbreak in South America in the Aedes aegypti mosquito. And so then what they noticed was a concomitant matching IUGR as well as microcephaly, because if acquired in the first trimester of pregnancy, then Zika virus can cross the placenta, infect the fetus, and they are negatively impacted. And you can have severe microcephaly and developmental challenges for those exposed in the first trimester of pregnancy. There is also risk in the third trimester of pregnancy, but it's unclear what that looks like. So we were saying don't travel for a very long time. Is there ongoing risk now that things have leveled out? The answer is yeah, there probably is. Am I going to be able to quantify for you a per bite risk? No, I'm not going to be able to quantify for you a per mosquito bite risk. So the general recommendation is a risk-benefit conversation. If you're an individual who's going pregnant in the first trimester of pregnancy and you're going to go traveling to an area where there's endemic Zika virus, would I pick that as my vacation spot? Depends how risk averse you are. You may also choose to eat sushi or not, or you may choose to eat unpasteurized cheese or not. But the identification of that risk for that individual is important and to help them making through that patient-centered decision-making process. So it's an ongoing conversation for those individuals who are traveling to those areas, and certainly any travel and pregnancy should be sort of couched in those conversations about looking what's available. What's next up? I can tell you that we're talking about Uropush virus right now, which is evolving in, again, South America primarily. And it might actually look a little bit like Zika because we are seeing some cases of microcephaly, some cases of miscarriage. We're still talking about monkeypox. We're still talking about those kind of things. Is it possible? Yeah, it's possible for those things to come out. So I didn't cover lots of things because I wanted to leave some time for questions. So I didn't cover vaccines, but I can tell you that yes, influenza vaccines are good in pregnancy and preconception. Yes, COVID-19 vaccines are still good and still should be taken. And then yes, because we have a shortage of neonatal monoclonal antibody in BC, your best option is maternal RSV vaccine. And I didn't cover a million other things, but I'm happy to answer any questions.
All right, thank you so much, Chelsea. I'm glad I gave you the easy topic. I'm not quite sure how to handle this because you have a lot of interest in your talk. There are a lot of questions here. but
Yeah.
we're already over time. So
Yeah.
I wonder if maybe we'll answer like two questions as succinctly as we can. And then if you don't mind, would you be able to answer them in the chat? Somebody asked about questions that have already been answered.
Sure.
In the chat, in the Q&A box, there's open questions and there's answered questions. In the answered questions, you should see questions that have already been answered by
Okay.
typed, unless they were answered live. Okay. Okay, so basically, there's a question, we'll just have to go. Is there any evidence or recommendation for screening for people for toxoplasmosis if they own or work with cats?
No. So again, it's a little bit like CMV a little bit, which is don't screen everybody. Toxoplasmosis is very prevalent. What you would screen is an individual who has a toxoplasmosis-like illness. So lymphadenopathy up the chain, those kind of things, like a mononucleus type infection in pregnancy, that's the individual you would screen. If you acquire toxo basically anywhere outside the first trimester of pregnancy, it's generally fine. Those people who have carry toxoplasmosis, the only time there's risk to them is when they become immunocompromised. And even in my individuals living with HIV whose CD4 counts are in their boots, babies don't get congenital toxo from people who are carrying it and actively immune to it. So really, no, there's no universal screening. It's for active symptoms consistent with toxo. Even with cats.
Same question, evidence or screening for people about parvovirus, IgM or IgG, if they're high risk, small kid at home, daycare worker.
Same thing, right? Which is no, it's only if there's an active illness. And again, it's like reinforcing good hand washing, avoid sick people while you're pregnant, get the vaccines that you can get. But no, I would not recommend universal screening for parvovirus B19.
Okay. Washout period after a live vaccine before trying to conceive.
Yeah. Do you want the manufacturer's recommendation, which is 4 weeks on most of them? The reality is there has never been an adverse outcome from a live attenuated vaccine in an early pregnancy.
Okay. This is rapid fire. We're making good progress.
Okay.
Question, what is the appropriate syphilis test to request for routine prenatal screening in an asymptomatic patient?
Yeah, good news. Tick the box, say syphilis screen pregnant, and they will sort it out for you. You will get your treponema specific test, and they will do a reflexive RPR.
And then same question around syphilis. If it's for syphilis PCR, can we use the chlamydia gonorrhea swab and just write syphilis on the Life Labs rec?
Yes, in theory you can. In reality, I call the microbiologist and tell them what I'm doing. And I say, hey, I think I have a patient with primary syphilis. I'm going to send you a PCR swab. Which one would you like me to send? And they usually say, go for it. And I say, okay. Because I myself have had some issues with not necessarily a microbiologist not running, but like the way it's processed is a bit learning. So I call, I say, hey, this is what I'm sending. But yes, in theory, you can.
Okay. And if HIV P24 antigen testing is positive and confirmatory testing is negative, would you expect the HIV P24 antigen testing to be falsely positive in future as well?
Yeah, hard to say. Some yes, some no. It's not clear. So we generally recommend, like, we often will see them, we'll help you work through the screening, help you work through the false positivity. But do I get them back in a future pregnancy with the same question? Sure do, sometimes.
Okay. And I think okay, I'll get one more. I don't want to leave you with so many questions to type. So one more. If you screened for CMV previously and they're not immune, then they get a cold with symptoms, do we need to look for seroconversion or only if there's ultrasound findings? And this question also says toxo and parvo, but we answered that. So just answer the CMV part.
Yeah, so any sort of mononucleosis-like illness, which we're all better at screening for those now, we're pretty good at viral illnesses. Yes, you should include that in your screening, and you should be looking for seroconversion, essentially, of CMV and a million other things, right? Because it's not just that. But yes, that would be an individual who you might have a high index of suspicion for looking for seroconversion.
Okay, excellent. So there are a lot of other really good questions on here. I tried to pick the quick answers.
Sure.
But if people want to look in the chat, I'm sure Chelsea will be there for the next while answering those questions. Thank you so much.
I will try.
I appreciate it.
Okay.